Happy Halloween.
Happy Halloween.
So we have a treat for you today, not a trick. The treat is we have Dr. Steve Luby, and Steve thought actually he's a man of many talents, including one that enables him psychologically to recover from a mental preparedness for a talk at 4 o'clock when it really was at 3:30. So fortunately, Steve has got so many talents. That's one of them is that he can give his talk half an hour earlier than mentally he was thinking what he had to do. So I'm sure most of you know Steve, that he got his MD at the University of Texas in Dallas, right? The Southwestern Medical School. Is that correct?
That's correct.
And then he spent a lot of time in Bangladesh. He was directing the Center for Communicable Diseases at the ICDDR in Dhaka in Bangladesh, and that's where he was most recently. And then we were really, really, really fortunate that we were able to persuade him to come to Stanford to do something, somewhat unconventional. He could have had his pick of the litter, as they say, in choosing any public health school in the country that were chasing after him, but decided to throw his lot in with Stanford and with the medical school, Woods Institute, and the Freeman Spogli Institute. So he's in this very interesting position where he's a senior fellow both at Woods and at FSI, but he's also in the Center for Global Health at the medical school, working on all kinds of interesting things. And I won't steal his thunder because I'm not sure exactly what he can tell you about today, but I'm sure he's going to tell you about a number of them. But it's been a great pleasure for me to get to know Steve over the last couple of years and to build this relationship and to help build our program in water health and development at the Woods Institute. So it's been terrific. So without without taking any more of your time, I'm almost stalled until 4, Steve. So it's just 20 minutes, and you can probably do it. So please welcome Steve.
Thanks, Jeff. I'm just thrilled to be here. I have been trying to talk about hand washing at Stanford for 2 years. And every time I recommend it, this doesn't sound like that's a good. When I first started to look at Stanford as a place, I said, well, wait, you could come and give a talk. I said, what would you like? And I said, well, what would you like me to talk on? Talk on anything. I said, well, how about I talk about hand washing? Maybe not. Maybe you could do something on Nipah virus. So then they called me back for a second visit. And they said, well, we'd like you to give another talk. I said, well, how about I talk about hand washing? Maybe you should think about what's the kind of things you would do here. So a couple months ago, I was asked to give a talk at medical grand rounds, primary appointments in the medical school, and I got medical grand rounds. I said, well, this is an area of my expertise. How about I talk about, and there's concern with hand washing in the hospital. How about I talk about hand washing? So when Cherie reached out to me and said, well, would you be willing to give an environmental forum in the fall? I said, what about if I talk about hand washing? She said, that sounds great. So I'm just thrilled that there are at least a few people that want to learn a little bit more about this. And I don't know why Stanford sort of has this reluctance to talk about hand washing. Maybe it's because sometimes they feel it's not the most cutting edge of topics. If we think back to where connections with hand washing and health got started, it was really with an obstetrician named Ignaz Simovice, who worked at the Vienna Lying-In Hospital as a obstetrician. And he noticed that there was a lot of puerperal fever, that is, fever around the time of childbirth, or childbed fever, it's sometimes called. And the Vienna Lying-in Hospital was split between women who came in and who were treated by midwives and women who were treated by medical students. And the women that were treated by medical students were actually much more likely to develop puerperal fever and die compared to those who were cared for by midwives. People knew this. Simovice was troubled by it, but even the women knew it. And they'd say, well, no, I want to go to the midwives ward. But it was assigned on day of the week. So one of Simovice's colleagues at the Vienna Lying-in Hospital was Jacob Kolchanka, who's a professor of forensic medicine. And he was implementing what was then a new approach of pathological anatomy. That is, when a patient dies, you try to figure out what they died of. Can we step beyond Galen and say the humors were out of balance? They would actually cut the body open and look and do an autopsy and try to figure out, well, that's what they died of. So Jacob and Ignaz were friends, and one day when Jacob was doing an autopsy with medical students, oh my goodness, see, 15 minutes. I'm supposed to have time here.
You're ahead of your computer.
For the first time. So Jacob is like Jeff, like myself, trying to get involved with students. Jacob was in there working with students, and one of the students pricked his finger while they were doing an autopsy on a woman who died of childbed fever. Because if they were doing these autopsies, it was a lot of childbed fever. And he went on to die of the disease. And when he died, this really troubled Simovice. And an autopsy was also performed on Jacob. And Simovice said, day and night I was haunted by the image of Kolchanka's disease and was forced to recognize that the disease from which Kolchanka died was identical to that from so many maternity patients who died. So this is before germ theory, this is before Pasteur, this is before Joseph Lister. He's saying, wait a minute. The medical students are going down and doing these autopsies. They're going back and taking care of patients. It looks to me like they're bringing something, and it looks like Kolchanka got that same thing. So Simovice developed an intervention in 1847. He said, all right, the medical students will continue to practice pathological anatomy, but they will wash their hands with chlorinated lime before they go back to take care of patients again, before they do internal vaginal exams and figure out whether the pregnancies are progressing. With that intervention, the proportion of puerperal fever in the student ward dropped to 2.4%, basically equivalent. So the conclusion 160 years ago was hand washing saves lives. So we're also supposed to be talking to early career students and what's your professional path going to be. So let's take a look at what Simovice's path was. Well, what he did is he didn't publish right away. He waited for 13 years. When he did finally publish, his findings were widely rejected in the medical establishment. Again, this is before germ theory. Come on, what's your proof? And people were really upset, saying, how can you accuse me of killing patients? In his time, his findings were not accepted. He developed progressive mental deterioration and was beaten to death in an asylum. As germ theory was later developed, it was recognized that he was correct and is now held up as somewhat of a hero and a pioneer. So why, 165 years later, are we still talking about hand washing? I want to look at the global burden of disease. if we look at why children die globally, there are 700,000 children who died in 2010 from diarrhea, and another 1.3 million who died from pneumonia. So if we think about diarrhea, this is a disease that hand washing might have an effect against. So it's one of the reasons why we are interested in evaluating this. So if we think about children that die in low-income countries, it's not just any child who gets diarrhea and dies. The children who die tend to be those who have the most immature immune system, so they're young, so they don't have much physiological reserve if they get an insult. These are the malnourished kids. They have a lot of they tend to have frequent infections, and they're surrounded by a contaminated environment, something that the woods would understand. There's feces in their water, in their food, and in their physical surroundings. And then if they do get sick, because they're impoverished, they have less access to care. So it's not just any child who dies, it's particular children at greatest risk. And so in this setting, we wonder whether can hand washing really make a difference. These kids already have so many other compromises going in. So we did a study in Pakistan in 2002 in Karachi looking at the effects of hand washing with soap on two outcomes, on child diarrhea and on acute respiratory illness. We were also interested in measuring the effect of skin washing on impetigo, on a skin rash, and measuring the marginal benefit of including an antibacterial compound in soap on the skin rash. So if you're perceptive students, you'll think, wait a minute, maybe the soap company was really interested in this objective, and you were adding on some other things. So the soap company wanted to be able to say antibacterial soap made a difference. So where did we do this? We did this in squatter settlements in Karachi, where the drinking water is highly contaminated with 10,000 fecal coliforms per 100 mLs, and their feces is, it's just a fecally contaminated environment. So these are water lines running over an open sewage, and people even going into the building over the line of open sewage. In this context, 10% of children died before their 5th birthday. 40% of those deaths were from diarrhea, and over a third of the children met the WHO criteria for malnutrition. So what did we do? We started with 36 neighborhoods, and then we randomized. 25 of those neighborhoods got soap, and 11 were controls. In the 25 soap neighborhoods, 300 of them got the antibacterial soap, and 300 got plain soap, and then there were 306 control households. So the interventions were antibacterial soap, which is chemically identical to Safeguard soap, but it was put in a generic package, so you couldn't see it, and it contained 1.2% trichlocarbon. Now, trichlocarbon is an antibacterial, rather weak antibacterial. You probably have already come in contact with it 5 or 6 times today because it's in all sorts of household products. It tends to inhibit the growth of gram-positive bacteria, which are not bacteria that typically cause diarrhea, but are the bacteria that cause impetigo, that cause skin infections, are gram-positives. The other folks got plain soap. So it looked the same, but there was no trichlocarbon. And then the controls got school supplies, books and the kinds of things, and pens and notebooks that the families valued. So each week, community health workers from the local non-government organization that was trusted went in and encouraged moms to wash their hands with soap. They had discussions in the local language, and they used these kinds of pictures to say what's going on and what should be going on. They answered questions that mothers would have, supplied soap, and collected information on illness. So specifically, the instructions were to wash the skin thoroughly once a day. Remember, Procter & Gamble wanted us to impact skin disease, and then to thoroughly wash hands at 5 key times: after defecation, after cleaning an infant who's defecated, before preparing food, before eating and before feeding an infant. So these are the classic World Health Organization times when you should wash hands, and I'm sure you all washed your hands knowing that you were going to eat afterwards too. So this is just to give you an idea of what's going on. So here's a mom in the study, and you see, so she's washing her hands. It looks like she's got running water. Actually, she's got a tank on the roof, and so the water runs intermittently. But we know what's in that water. And so she has her bar of soap, so then she takes that fecally contaminated water and lathers up, and then what's she going to do? How's she going to dry her hands? Yeah, I mean, there are no air dryers here. She's going to use her dupatta. So this is not a surgical scrub. We didn't make this perfect. We did give them soap. We encouraged them to use it. But we actually expected them to work within what we knew was a constrained environment. So if you look at how these groups were at baseline, remember we did a randomized controlled trial, well, the groups are pretty similar at baseline, and even in the control group, they're buying a couple bars of soap a week. So again, this is not soap versus non-soap. This was a lot of encouragement for hand washing versus none. So these are the data. If you look here on the y-axis, this is the percent of person days with diarrhea, and then the x-axis is time over the 1 year of the study. The black is the control group, the red is the antibacterial group, and the white's the plain soap. So what do you think? I mean, we see a pretty big difference between antibacterial, between soap and control. About a 50% reduction. Took a little while before we saw the change, but then over time, pretty big differences. And not much difference between antibacterial and plain, but that doesn't surprise us. These are gram-positive organisms. We worry, though, that the kids who die are the youngest kids, and those children under the age of 1 year do not wash their hands with soap. In fact, none of these kids are washing their hands with soap. So one of the questions is, well, this is kind of silly to do an intervention where you're trying to save moms' lives and you're not even washing the hands of the kids, and we know the kids are sticking their hands in the mouth all the time. So are you really reaching your target population? Well, what we find is that, in fact, the older folks did have a larger reduction in terms of percentage, but we did see reduction in diarrhea amongst the youngest children. So yeah, they weren't washing their hands, but other people were washing their hands in the household, so maybe there was less transmission to the kids. Similarly, we talked about it was the children who were at highest levels of malnutrition or at highest risk of death. And so we're not just interested in decreasing any diarrhea, we're actually interested in decreasing mortality. And again, we see that even among those children, severe risk of death, or severe malnutrition at highest risk of death, we also see decreased diarrhea in them. So some sense that even though this is a constrained environment, we're still benefiting the most vulnerable. We didn't stop with diarrhea. We also looked at pneumonia, and for pneumonia we followed a case definition, which is really comes down to how fast the child is breathing and depending upon how old they are, and we timed that with a watch. And if we look at this over time, what you see is that in the two groups that got soap, their episodes per 100 weeks of pneumonia was pretty similar during the year, while during the winter time there was a big peak in the control group. So again, there was about a 45 to 50% reduction in disease in these groups that got soap and hand washing promotion. And again, under age 1, we saw some difference, not as big as in the other groups, but at least some suggestion that it was coming down. And similarly, even in settings of severe malnutrition, we saw some benefit on hand washing on reducing pneumonia. How about impetigo? Well, there's a season of impetigo. Summer came, the impetigo came, and It was definitely less in the soap groups, but not much difference between the medicated soap, the antibacterial soap, and the plain soap. So what did we conclude? We concluded that children who lived in households, of course I keep pulling all the hand washing back there because that's where hand washing would make the biggest difference.
Hi. I'm wondering in terms of measuring hand washing, if there are, if you can use like ratios that you observe between reported behavior and observed behavior to kind of use that as a proxy to get at actual.
Yeah, we've thought about that some, and it's just really hard to know whether those ratios are meaningful and what all is going on into a response that says, yes, I'm hand washing. What does that really mean? Does that mean that I know when I'm supposed to be hand washing? Does it mean that I know that you know that I should know that I should be hand washing? And particularly given the fact that the observation data is also biased and is not linearly biased, but is biased based on education and wealth, it makes it very hard for me to think about how do I correct this when I don't believe the gold standard. Now, the other way we've tried it is we've tried to look at what are health outcomes and then said what are the hand washing behaviors within the Shea-Wabi group that is associated with health outcomes. And so we find things like that water at a hand washing station is associated with fewer episodes of respiratory disease in children. So maybe we think that, if you will, gets around some of these questions. But myself, there's an adage in epidemiology. We don't want more data, we want fewer data of higher quality. And I just despair trying to disentangle what people mean and what connection that has to what they're doing.
Yeah, habit formation is something that happens over time. These measurements are so much about diarrhea and behavior at one point, and then some we could say somewhat long time later, repeating that measurement once. Shea-Wabi study, we don't know. They could have been successful in changing behavior for a week and then went away. So how do you intend to control for that dimension?
No, I think there's a great question. I mean, if you think about habit adoption takes a while to do, and so part of what I'm arguing is that we should think about it as habit adoption and think about it as a process and think about it over time. We're not trying to change one thing. It's no, now every time you get on a bicycle, I want you to wear a helmet. Every time you get in a car, I want you to put on a seat belt, right? Every time you come from toileting, I want you to wash hands with soap. So I do think the metrics then change for that. And one of the at Shea-Wabi, we've now gone on and we have 5 years, and you can kind of look at things a little more over time. But I do think the habit adoption requires a lot of repetition, and a lot of repetition so that this becomes unconscious. It's again why I believe in an enabling environment. An enabling environment gives you cues and makes it easy to do. So most of the evaluations are short-term, and I think we should recognize that what we want is longer-term change, and we need to focus in those areas. Yeah, it's a good critique.
All right, we'll just take a couple more. Terry, I know you wanted to make a
I have two. You said something about dental hygiene. Do they have dental hygiene?
Yeah, they have some dental hygiene.
So I was thinking about actually putting those two hygienes together. If they have dental hygiene, then at least you can have them wash their hands once a day. Is that possible? They're at water. They're going to, I assume,
I think it's a very clever suggestion, and I actually like the idea of saying, can we get people to wash their hands once a day? Maybe we shouldn't even think about key times. Let's just is there once a day or is there twice a day that we get hands washed with soap? Because maybe that's more achievable. I think it's a good suggestion. And one of the funny things about toothpaste is toothpaste has peppermint in it, and that was added by Pepsodent. And what that does is it gives you a signal that says, oh, wait a minute, oh, I brushed my teeth. And so I'm betting that everybody in this room brushed their teeth before they came to the office today. And so we've connected this habit. Okay, many of you would have.
All right, I'll take, I know there's a lot of questions. Maybe did you have one? Inside question?
I was wondering, Steve, if you could talk a little bit about the role of technology development in terms of scaling up hand washing, especially in places where there's not piped water supplies. We already mentioned waterless hand sanitizer, but what about soapy water? I know you didn't really spend much time chatting about that. Or other technologies that could make hand washing easier and take less time.
Yeah, no, I mean, I think it's a really important issue is if we continue to use the same tools and the same approaches, we're going to continue to have the same low levels of uptake. And if some of our barriers are clearly infrastructure, we believe, I believe anyway, that the cost of soap matters a lot. And so the idea of soapy water is not going to move us from 11% to 95%, but it's overcoming a major barrier. And in those settings where water is short, it still is sensible to think about how do we get appropriate water to make a difference. And so, yeah, I would say the area is ripe for technology development, but also we need to keep in mind that these are low-income settings. And so how do you actually do this in the context of a lot of poverty, and particularly when it's the most impoverished kids who are at highest risk of death?
All right, we'll take two more. Terry, all right, three more. Terry, David, and that's it.
So why are soap
I will take five more.
Why are soap companies still selling antibacterial soap if it doesn't make a difference?
I think you know the answer. Because people like to buy things that say antibacterial on it, and so it's a marketing advantage. And then there are big tussles with the FDA over this. And my recommendation to soap companies is to take it out, because you're going to have to anyway and get on the right side of history on this one. It just doesn't make sense for me to pour tons and tons of trichlocarbon into the environment. And it's a biologically active compound. But no, if you look at their advertising for all of the major soap companies, they all argue about antibacterial on some level. Yeah.
So I'm looking at about the water and mud treatment. Might have implications for my company. So is there a basis in that? And is it, I mean, you might have shown it, but I missed it. Is there data to show why that's effective?
Well, no, I didn't show the microbiological data. This thing was getting kind of crazy. That's why, if you notice, I didn't have slide numbers on there. If you look at water alone in terms of washing hands, you reduce indicator organisms, indicators of fecal contamination by about 1 order of magnitude. If you wash your hands with water and soap, it's 2 orders of magnitude. There's been one nice study done in Bangladesh by Bilkis Hoke, looking at using mud or ash instead of water or soap in a water scarce setting, and has shown some reduction, almost a log of reduction, but it also appears, it looked like it did better with ash than with mud. And one of the reasons is if you think about the population density in Bangladesh and you think about mud that's around, you're also going to be introducing contamination. Does that answer your question?
Well, I'm just wondering, for non-contaminated mud, it's pretty effective, it's more effective than water.
Well, no, I wouldn't say than water alone. I mean, so mud can, okay, I mean, do you really believe, I mean, soap is remarkable because of its surfactant capacity, so it, removes all this organic matter. The USAID wanted me to do a mud and ash study because this question comes up a lot, and saying, oh, wouldn't it be better to just have people use mud or ash, which would be lower cost? But people don't want to use mud or ash in rural Bangladesh. I think we might have been able to do the study 25 years ago, but we can't do it now. Now, your kids probably want to, and I'm sorry, I'm just going to have to plead that I can't give them definitive guidance.
You get the last question.
Well, it's actually two, so I apologize.
Oh.
So one is, in these intervention studies, have you ever tried just using friction? So people, because I think that that's a big part of why ash or mud would probably work, is just through using friction.
Right.
That's a very low-cost option. And then the second one being, in the SHAO-B study, you didn't present any data on, and I don't know if there is data on any diagnostics or bacterial species that exist, and maybe it's not coming from people's hands, it's coming from something very different, and so the hand washing intervention is not exactly measuring whether or not it's effective or not because of the infectious agent is somewhere completely different.
Friction, I love it. This is great. This is great. Now, Lily, write this down. I think you're right. I mean, even part of an enormous reason why soap is effective is because of its mechanical action. I mean, it's mechanical, and I don't think it's because the surfactant is disrupting the bacterial wall. No, I think it's mass removal of organic matter that provides a microenvironment for transient organisms that are pathogens. And I really like the cost. So I think that's worthy of more consideration. I guarantee you I would need to have another intervention group before we could get somebody to fund it, but we'll think about that. And okay, do I think that there might have been diarrhea coming from other pathways in rural Bangladesh? I think almost certainly. However, it's one of the reasons why I started with the study from Pakistan. Is often people come and say, well, wait a minute, hand washing can't possibly be that important because people are also drinking contaminated water, they're eating contaminated food, they're living in contaminated environments. And the data from Pakistan are pretty consistent with data from other places, that there's still something really important with the proximity of how our hands contact the environment. And I think particularly with hands contacting food that then sits for a while and has an opportunity for bacterial growth. I suspect that that's really important.
To answer the question. All right, so I have to tell you a funny story because it's perfect. Steve's going to love this. If you ever go to Stanford Sierra Camp, how many people have ever been there? So you get there on a Saturday, right? And then everybody gets together and they give you this big lecture. Dave Barnes, who's the camp director, and they talk about the importance of not letting, some kind of diarrhea or flu or something spread through the camp because it will just kill everyone. It's just it just goes through like wildfire. So he has everybody sing. The song "Row, Row, Row Your Boat." So let's sing "Row, Row, Row Your Boat," right? And so we have to sing this stupid song, And then he says, "That's the time that it took to sing the song is how long you should spend washing your hands before you come into the dining room." So remember, when you stand here washing your hands, maybe you need to be singing "Row, Row, Row Your Boat." It's not, because and I don't know how true that is, and we're going to discuss it over, but I don't know if the time that is important, but it seems to think that if it is, then there's a friction thing there that could be. So with that story, let's go row, row, row your boat right out there. You believe that?
No, I'm